Welcome, friends, to my channel. Again, I'm Salah Abbas. I'm an associate professor of surgery at Deakin in Victoria, Australia. I have been teaching medicine for a long time, and it's one of my passions in life. I'm specifically interested in teaching medical students, although I teach postgraduate and surgical trainees. As I promised you, today we are going to talk about portal hypertension and variceal bleeding, or bleeding from esophageal varices. Before we talk about varices and how they form as a pathologic entity, we have to learn a little bit about the portal circulation. We know the portal vein is one of the most vital structures in the human body. The blood that drains the entire gastrointestinal tract goes from the inferior mesenteric artery, which drains the colon, distal transverse down to the rectum. Then it will join somewhere with the splenic vein, and then they will join the superior mesenteric vein. The superior mesenteric vein drains the entire gut from the ligament of Treats or ligament of Trites down to the splenic flexure of the colon. We will also get some epiploic veins, and around the head of the pancreas there is particularly a small vein that run from the head of the pancreas on the right side and join the portal vein as the portal vein emerges from underneath the neck of the pancreas. So all that blood that gets absorbed from the stomach, from the gastroesophageal junction down to the rectum, all goes through the liver for the first pass effect of a variety of nutrients, toxins, medications can get filtered through that, and so on and so forth. And the portal circulation is vital. The liver have dual blood supply with the hepatic artery, which supplies about 25% of the volume and 50% of the oxygen. The rest of the volume and the rest of the oxygen is provided by the portal vein. Portal hypertension is defined as increase in the pressure of the portal vein to more than 10 millimeter mercury. That's the normal range of the portal venous pressure. And that is something that can be measured. There are direct and indirect ways to measure it. Doplex and Doppler ultrasound is a good technique that could be used to ensure patency of the portal vein, but it is less not accurate in determining the pressure in the portal circulation. Certainly, it can tell you the direction of the flow, whether the blood is flowing toward the liver or away from the liver, as what happens in portal hypertension. The best way are the direct measurement, which is the cannulation of the portal vein through the skin into the portal vein under ultrasound guide, and the pressure can be measured. However, this has been superseded by the measurement of the hepatic wedge venous pressure. And the wedge pressure is a relatively simple technique. It's done through the jugular vein and then cannulation of the inferior vena cava to the hepatic veins. And the wedge pressure that gets read in there reflects the portal pressure. Now, this, in terms of practical use for the hepatic wedge venous pressure, we use it to assess the degree of portal hypertension in patients who are undergoing an assessment for liver resection, mainly for hepatocellular carcinoma. And we try to avoid operating on patients who got portal hypertension. They don't tend to fare well after the operation. That's why we do measure their portal pressure to ensure they are suitable and will recover likely from surgery. Now, There are few causes of portal hypertension, and these can be summarized in this slide as the major causes. So, good liver cirrhosis, regardless of the cause, you look at the liver, and the liver surface is irregular and nodular. And there are nodules all over the liver, variable in size and shape, and that what happens uh, if there is alcohol abuse, patients with hepatitis C and hepatitis B. We also see increasing number of people who develop non-alcoholic steatohepatitis, and that is part of the metabolic syndrome of obesity that can eventually lead to liver cirrhosis. People who have hemochromatosis, it's not a common condition for liver cirrhosis, but is an important cause. And if it is identified, it can be treated prophylactically to prevent liver damage. Yet, we have got patients who develop cirrhosis where there is no identifiable cause, and that's called idiopathic. The other variety or other group that develop portal hypertension are patients who develop portal vein thrombosis. Now, there are risk factors for portal vein thrombosis, and I have summarized the main ones that you need to know. And these are patients with hypercoagulable state, like deficiency of vitamin C, protein C, protein S, the Leiden factor 5, and people with antiphospholipid syndrome. The other group is people with myeloproliferative disorders, and these are like chronic myeloid leukemia and myeloid dysplasia, and the syndromes that are associated with it, and there are a few of them. They tend to have hypercoagulation, and they can get problematic venous thrombosis. Also trauma, whether it's a major road traffic accident or also after abdominal surgery, there is a risk of portal vein thrombosis. If we see portal vein thrombosis in general as an acute condition, we try to treat it non-operatively, and we coagulate the patient, anticoagulate the patient for 6 months, will be fully anticoagulated, and you'll find the majority of them will recanalize, but some of them will not, and they will develop portal hypertension with the possible consequences of that of varices and ascites. It's important to know a little bit about the pathogenesis of esophageal varices. The lower esophagus at the gastroesophageal junction have got a collateral system where some of the blood from the portal circulation can escape to or potentially escape to the systemic circulation. So when we have high portal pressure, more than 12 millimeter mercury of portal pressure, these collaterals will either recanalize or get bigger in size to shunt the blood away from the liver and into the systemic circulation. The other sites are the paraumbilical region, where you have the umbilical veins. Also, we have the lower rectum, where you can get massive hemorrhoids and rectal varices. They are rare, but they can be problematic, and they can bleed similar to the esophageal varices. Also, we do have retroperitoneal collaterals that shunt blood to the systemic circulation, but they are of no consequences. Now, this is the process of shunting, is the way of the body to divert the blood away from the liver. It happens in advanced liver disease, and it is the cause of what we call hepatic encephalopathy. And that will be characterized by memory changes, personality changes, drowsiness, and increased sleepiness. Now, in patients who would develop portal hypertension, not all of them bleed. Probably a third to half of them only will have problematic bleeding. These patients almost always have a portal pressure more than 12 millimeter mercury. They tend to have advanced liver disease. The probability of bleeding varices, if the patient has not bled, is governed mainly by the Laplace law here, which states that the tension on the wall of the vessel is responsible for the bleeding, and that's is related to three factors. Wall thickness. So if the wall is thin, it's more likely to bleed. Also, the transmural pressure, which reflects the portal venous pressure, and the radius of the varix, which reflects the size. Also, on endoscopy, if we look at them, we can tell if they are massive and they have got what we call the red whale markings, which is kind of red streaks in the epithelium that covers the varices. These are risk factors for bleeding in the future. Now, often you see people or patients with liver disease, they will get surveillance for their liver disease by a hepatologist to check the progress of their liver disease and also to prevent or early detection of hepatocellular carcinoma. For that purpose, they all get enrolled in a hepatology clinic with six-monthly ultrasound scan, liver function test, and alpha-fetoprotein. And they will, at some stage, get an endoscopy. The purpose of the endoscopy is mainly to see if they have got esophageal varices. These patients have not bled yet. So what can we do? Do we treat them or we don't treat them? It is a bit of a dilemma, but most clinicians would agree if they are small, they could leave them and do regular endoscopies every 3 to 6 months to check on the progress. However, treatment is available, and we probably in general tend to overtreat patients just because of the difficulty of prediction who's going to bleed in the future. The mainstay of the treatment for prevention is endoscopic and medical therapy. With the endoscopy, you can do endoscopic ligation, which is similar to ligation of the hemorrhoids. If you have seen that, it's a rubber band that goes around the varix after the main varix being sucked by the device that's mounted on the gastroscope. And then the band gets slipped and it will cut off the blood supply of the varix and will lead to healing of the area with scar tissue. Sclerotherapy is one of the famous methods of treating those instead of band ligation, and it is less effective, but it is quite an effective where materials such as phenol and almond oil or sodium tetraidactyl get injected and usually get injected at the gastroesophageal junction below the varix and just above the varix itself. And they seem to provide a good way to control bleeding and treat varices in the long term. Now, if we present with a patient who come to the emergency department with bleeding, they do present usually with hematemesis, and often they come in a dire situation. Usually the bleeding tend to be massive, and the mortality rate is almost 50% in the first instance when they bleed from the varices. So we need to know how to manage them quickly and efficiently, hopefully to get them out of the trouble. Obviously, the first thing you need to do is the resuscitation, and with your resuscitation, in your mind, you'll have two lines, large bore cannulas, and also a central venous line, which is put in later on after the patient has been more or less stabilized, or at least given a few units of blood. So we restore the volume, and the volume could be restored with crystalloids or albumin. But my preferred resuscitation method, as I mentioned in the previous lesson, is blood. So we cross-match at least 6 units of blood, and we need to know their coagulation situation. Now, the coagulation system in liver disease, particularly when the liver disease is advanced, tend to be very tricky because you get increased fibrinolysis, and at the same time you get prolonged thrombin time and prolonged IPTT and low platelet count. So it's very tricky to get around that, which means that along with the blood, we have to have coagulation products, and these usually in the form of either prothrombinics, which is the concentrate form of factor 10, or we use alternatively, other than fresh frozen plasma, vitamin K can help as well. And platelet count usually in patients who have got portal hypertension are low. Now we know that if the platelet is more than 50,000 per mil, you will not need to, or there is no benefit to do platelet transfusion. But if they are less than 50, we certainly would start with 2 units of platelets and check the count in the next run of blood test. As I said, we put a central venous line once we started the process, and usually in each hospital there is a massive transfusion protocol that can get activated in the hospital, which will link you to the hematologist and to the blood bank to provide you with the necessary products. Now, the mainstay of the treatment in these situations when they are bleeding, after after ensuring hemodynamic stability, they go to the endoscopy to be scoped by an experienced person who can do rubber banding or injection with sclerosing agents. And banding or ligation of the varices is a very effective treatment, and it controls this situation in about 85% of the cases. These patients are at risk of developing aspiration pneumonia and infections, so they will get started on some intravenous antibiotics, usually in the form of cephalosporins or alternatively amoxicillin. So we correct their coagulation changes, and we check their coagulation status after each transfusion. And then they get to the endoscopy suite, and hopefully successfully they have been ligated and the bleeding has stopped. Then the patient will go from there to the intensive care unit. And the medical treatment that we will need to institute tend to be very effective. We have got what's called octreotide. It's the trade name for somatostatin. It's an analog, a synthetic analog of the hormone somatostatin, and somatostatin is a hormone that gets secreted by the pancreas. So they get a bolus of 50 microgram intravenously, and then an infusion that run at 50 microgram per hour. Usually we'll find this will go on for minimum of 48 hours. Vasopressin or desmopressin is the antidiuretic hormone. The same hormone can be used to reduce the portal pressure. Both these agents have a feature in common, is that they reduce the portal venous pressure by reducing the visceral circulation, or the splanchnic circulation, rather. With vasopressin, patients will get 20 units over 20 minutes in the first instance, and then they will have an infusion of 0.2 to 0.4 units per minute. That will be in the intensive care unit where they are monitored. They can have cardiac complications and side effects from the vasopressin, and it is advisable that once you start the vasopressin, you also put the patient on GTN infusion at a rate of 40 microgram per minute. These medications are very effective, and they tend to help in controlling the bleeding process. And very often you will find that they get instituted, or at least bolus doses get started even prior to the endoscopy. Now, in certain situations, it can be quite difficult, and the bleeding does not stop. There is a mechanical method to stop the bleeding by using a tube that's called the Sengstaken-Blackmore tube. Now, the tube has got 3 lumens to it, and it gets inserted via the nose, just like a nasogastric tube. Once you position it in the stomach, then you inflate the balloon through here. You inflate the balloon that sits in the stomach, and then once that inflated, usually takes about 50 mils or so. Then you pull on the catheter or the tube itself until it goes tight at the gastroesophageal junction, and then you inflate the sausage-shaped balloon, which is the esophageal balloon, and the pressure will control the bleeding. This is not my favorite method of controlling bleeding in this situation. I think I have only used it on 1 or 2 occasions when there were no other measures that would stop the bleeding. And this situation can arise in the emergency department if the patient is exsanguinating, and while you are resuscitating the patient and waiting for the endoscopy, this is certainly an option that you can opt to bridge that to endoscopy when the endoscopy suite and the endoscopist will be available. It does control the bleeding at about 85% of the times in acute situations. But it comes with a few problems. One of them is that once you remove deflate the balloon and remove it, you've got 50% recurrence rate. Now, when we remove that, I recommend that it get removed in the endoscopy suite where you're ready to put the endoscope in with an experienced person who can inject or ligate the bleeding varices. It also, as a result of the pressure on the wall of the esophagus, can lead to pressure necrosis and perforation of the esophagus, in addition to the risk of aspiration and pneumonia. Now, hopefully, the patient had survived their episode of the first bleeding, and we managed to get them out of the hospital, or at least out of the intensive care unit, and now we make a plan for them in the long term. And the reason we do that is because the recurrence rate is 70%, and mortality rate with recurrent bleeding is extremely high. So we need to involve a hepatologist who will look after their liver and see if there is anything that can be optimized. Often it's around diuretics and stopping alcohol, and that is out of the topic that I'm going to talk about today. We leave that to the hepatologist. What will they get? They will get regular endoscopies every about 3 to 6 months, and they will get put on beta blockers that proved to reduce the risk of rebleeding by reducing the pressure in the splanchnic circulation. Now, I should mention to you the role of surgical shunts. Surgical shunts were a big thing in the past, such as porto-caval shunt or mesocaval shunt or splenorenal shunt, proximal, distal. This has almost totally been abandoned to treat people with portal hypertension for a variety of reasons, and one of them is the fact that these patients are high risk for surgery. If you operate on them, there is a high mortality rate associated with it. There is significant damage can happen from increasing hepatic encephalopathy, which means their liver function will deteriorate. So surgery is more or less out of the question. And emergency surgery is rarely needed. have never been involved in anything like that, hopefully never. But transection of the esophagus or anastomosis is the method that has been described to be the least invasive. It's in an open fashion where you put a circular stapler and you fire it at the gastroesophageal junction, which work like cutting and anastomosing. I'm not sure what the mortality rate associated with that, but I suspect it's high because usually it's needed in people who are already very sick. So we try to avoid that at all costs. What have replaced surgery is what's called the TIPS technique, which is the transjugular portosystemic shunt. It works with your interventional radiologist who is experienced in this type of technique. They go with a needle and a guide wire down the internal jugular vein, down to the hepatic veins via the inferior vena cava. Once they get into the liver, then a needle will be directed to cannulate the nearest branch of the portal vein, either the right or the left. The right is preferable because it is bigger than the left and supplies about 70% of the liver. So they will go intrahepatic with a needle and a wire, and then the needle get into the portal vein, and they advance the wire. And based on what's called the Sildinger technique, which is universal for interventional radiology, then they can deploy a stent that will shunt the blood from the portal vein into the hepatic vein, bypassing the liver parenchyma. It's a very effective method of as a shunt, but it is associated with encephalopathy, other complications. And the trouble with it is the fact that about 50% of the time, or 50% of the patients, the stent or the shunt will get blocked in about 12 months, which might need redoing. Now, a lot of these patients will be worked up by the hepatologist for their suitability or for liver transplant. And if in a regional center they thought to be suitable for liver transplant, then they get sent and referred to the liver transplant center for further assessment. And hopefully the TIPS can work as a bridge for them to get them by until they get to liver transplantation, which will be the ultimate treatment to resolve their liver failure as well as their problem with the portal hypertension. Now, I kept it very concise and hopefully short, but I think it's going to be hopefully very informative and useful to you in your exams and also in your clinical practice in the future if you happen to look after one of these patients with bleeding varices. Thank you much for watching, and I will look forward to see you the next time. Please subscribe to us and send us your comments and suggestions. See you next time.